Shellshock, an early identified form of PTSD, is a set of war-induced symptoms that affected soldiers during and after the war, where their symptoms were perceived as cowardice, emasculating them in the post-war transition. During PTSD shellshock, the process of catecholamine neurotransmitters dopamine, norepinephrine, and epinephrine in forming and processing memories is impaired. Evidence shows that from the increased urinary and plasma levels of dopamine in individuals with PTSD, that there is a positive correlation between dopamine levels and the severity of PTSD. It was typically a result of trauma, a psychological wound caused by the constant bombardment of artillery shell explosions and their byproduct shrapnel. Especially in World War I, where trench warfare was regularly used, soldiers were trapped for long periods of time in disease-rampant ditches, often near constant bombardment. Its symptoms are caused by remembering distressing and unforgettable memories that provoke crying, fatigue, tremor, nightmares, insanity, terror, amnesia, paralysis, and lack of movement, plus confusion, plus inability to communicate, a group of symptoms known as catatonia. In the early 20th century, PTSD and its associated symptoms had not yet been recognized, and thus shellshock was considered a psychiatric illness. 3,000 years ago, these symptoms were first recorded on cuneiform tablets inscribed in Mesopotamia and were believed to be caused by ghost hexing. Shellshock then went from being considered a legitimate physical injury to being a sign of both the battalion and the soldier's weakness. It wasn't until the 1880s that psychiatrists connected the symptoms to the brain, but even so, it was associated with poor morale plus defective training. The true cause, prolonged exposure to wartime stress, would not be fully understood and therefore not effectively treated throughout the war. The symptoms developed from psychological trauma chronically affected many veterans after the war. By World War II, the issue of combat-associated mental health ramifications were increasingly brought to the attention of psychiatrists, who concluded that too many men who were prone to anxiety or neurotic tendencies had been selected to serve in World War I. However, despite 6 times as many American men being screened and rejected for service leading up to World War II, twice as many American soldiers showed symptoms of PTSD in World War II than World War I. This is most likely due to more battle casualties, as fatalities had tripled from 116,000 in World War I to 405,000 in World War II. Shortly after and during World War II included the major progress in understanding the pathophysiology of traumatic brain injuries by Denny Brown, Russell, and Holborn, promulgating the use of helmets to prevent motorcycle injuries by Cairns, development of comprehensive multidisciplinary neurorehabilitation by Rusk, and development of spinal cord injury care by Monroe, Gutman, and Bors. Doctors had known very little of what we now call PTSD, or post-traumatic stress disorder, and there were few treatments for veterans who suffered from the mental trauma caused by war. Soldiers have been glorified as heroic and brave through propaganda and have been archetypically considered as honorable for dedicating their lives to the nation's cause and for embodying nationalism. So when they came home unable to communicate, walk, or remember with no clear reasoning, the only possible explanation was personal weakness and cowardice. Treatment methods were based on the belief that the soldier who had entered as a hero was now behaving weakly and had to be snapped out of it. During World War I, 10,000 Canadians have been diagnosed with shell shock by doctors, and the medical treatment ranged from gentle to cruel. Freudian techniques of talking and physical therapy, based on Sigmund Freud's theories of psychoanalysis, helped many soldiers recover. More extreme methods included electric shock therapy, where patients were electrocuted in hopes of stimulating paralyzed nerves, vocal cords, or limbs to induce seizures. Before ETCs, this was done with the use of chemicals, especially one called metrazole. By many reports, patients experienced feeling terror after taking metrazole just before the seizure started. However, the latter, electric shock therapy, was more effective in returning soldiers to the front, where about 2/3 of all patients returned, although how many relapsed is unknown. The transition process was difficult whether or not soldiers experienced PTSD symptoms. During war, soldiers' only concern was survival, but at home they had to worry about bills, food, and integrating back into society. Many veterans felt obligated to carry out the dreams of their fallen comrades, which led to lack of personal direction and purpose. There are 5 stages that classify the process. Number 1, veteran with entitlement. These veterans believe they are entitled to receive help for serving. Number 2, veteran self-pity. These veterans carry survivor skill and imagine the should-haves, could-haves, and would-haves. This type of veteran doesn't realize he is wasting the very life his fallen friend would have done anything for one more day of. Number 3, veteran with identity issues. These veterans hold on to military years as that is what defines them. However, their ability to adjust back into society is affected by their identity issue. Number 4, veteran who feels like being a veteran makes them better than the rest of society. These veterans think they're better just because they served and deserve more. Lastly, number 5, the veteran who gets through these stages to realize he is a civilian now, a civilian who has tools he learned from the military, and that these tools can make him successful.
Let's all meet in Dying Festival. That's a drugstore that had a soda fountain. And I said, let's meet there and have a cold Coke after the war. And Bruce looked at me. And he said, Robin, I'm not going to make it.
Compared to the general population, veterans experience higher rates of both PTSD and suicide. Suicide is a critical issue for veterans as combat veterans are more likely to act on suicidal tendencies, especially since they are less likely to seek mental health professionals. Some studies link suicide risk to the PTSD symptoms of distressing trauma memories, anger, and poor control of impulses. Furthermore, suicide risk is higher for those who tend to bottle in their feelings. In America, veterans who tested positive for PTSD were associated with a 58% higher risk of suicide right after screening compared to veterans without PTSD. One study examined all suicide deaths from 1994 to 2006 in Denmark and discovered people with PTSD had 5.3 times the rate of death from suicide than people without PTSD. A following study examined suicide deaths from people diagnosed with PTSD in Denmark from 1995 to 2011 and found that after adjustments for demographics and pre-existing comorbid psychiatric diagnosis, PTSD people had 14 times the rate of suicide than without. Over the last several decades, alcoholism has become a major concern for current and former military members. Alcohol has been used as a coping mechanism during difficult times to mask triggers of trauma and to help forget terrifying incidents. Frequent binge drinking can rewire the brain, increasing alcohol dependence over time. When a veteran has PTSD, their symptoms can be prolonged, as well as exacerbated from alcohol consumption, leading to increased risk of self-harm and suicide. When alcohol enters the body, serotonin and norepinephrine levels are decreased. Serotonin is a chemical that affects your mood, appetite, sleep, and memory. Norepinephrine is a stress hormone that controls how the body reacts to different situations and events, and low levels of both serotonin and norepinephrine have been linked to depression. Veterans are also at a risk of being diagnosed with a co-occurring disorder where two conditions, substance abuse and a mental health disorder, such as anxiety or PTSD, are simultaneously diagnosed. Both conditions must be treated and addressed together to prevent more serious health complications from arising. Shellshock victims often couldn't eat or sleep, while others suffered physical symptoms. Many soldiers found themselves reliving their experiences of combat long after the war had ended, and around 80% of shellshock victims would never be able to return to military duty. Officers especially suffered some of the worst symptoms and exemplified resilience, as they were forced to repress their emotions to set an example for their men. Many soldiers suffering from shell shock were charged with desertion, cowardice, or insubordination. The unlucky ones were tried and convicted. Some shell shock soldiers were executed by their own side after being charged with cowardice, and they were not given posthumous pardons. In conclusion, PTSD emasculated the men post-war and led them to experience a lifetime of suffering. In a time of dominating nationalism, deserting the battlefield was an act of treason and costed the soldiers' lives and familial honor. Their courageous step onto the battlefield was tarnished by the action of stepping out, and their contributions will not be recognized after their deaths.